Could you discuss issues in the management of HCV patients whose disease places them in more than one of the left behind categories of genotype 3 infection, cirrhosis, renal failure, or triple therapy failure?
It's interesting that you mentioned the term left behind. Until very recently, we would have thought about those groups as having been unmet needs in the treatment revolution for hepatitis C. As is, I think, well known to most of the efforts in drug development for hepatitis C have been focused on genotype 1 infection. And we've made tremendous strides in improving overall response and cure rates in that group of patients. So interestingly, as we look at genotypes 2 and 3, the other major genotypes here in the United States and for that matter worldwide, we've noticed that sustained response rates actually diverge between 2 and 3, which we had formerly lumped together previously as being easily treatable. Those patients on the old pegylated ribavirin regimens had high rates of success, but as it turns out, with the newer agents, specifically sofosbuvir in combination with ribavirin, when applied to genotypes 2 and 3, have resulted in lower rates of response, about 60% compared to the 95 to 100% rates of response we saw in genotype 2. So there really is divergent behavior between those two genotypes. So we really have kind of corralled out genotype 3 as now our perhaps most difficult to treat genotype among HCV, at least in this country. That said, there have been increasing efforts to develop agents that have increased activity against genotype 3 hepatitis C, and moreover, combinations of agents, namely sofosbuvir, ribavirin, and ledipasvir, the same agent I referred to a moment ago as being active against genotype 1, turns out that combination enhances the activity of the regimen against genotype 3 as well, with very, very good response rates described in a small study presented recently. So we're encouraged that perhaps even with a new wave of approvals that are imminent, we may be able to actually make a significant dent potentially in genotype 3. To be sure, there will be another wave of more genotype 3 specific agents, but it's as if we now are playing catch up with that particular genotype, given our success recently demonstrated in genotype 1. As for cirrhosis represents a real challenge. Consistent data across studies demonstrate some drop-off in success rates in cirrhotic patients compared to non-cirrhotic patients in general. This may be due to several factors, including perhaps diminished access of the drugs into a cirrhotic liver because of the limitations of scar tissue, limiting the access of drug to those cells, for instance. Or there may be something about the immune milieu of the patient who has cirrhosis that limits their ability to respond perfectly or ideally to these regimens. To be sure, though, we are also seeing in that group of difficult-to-treat patients real strides in terms of combining agents, direct-acting viral classes, so that 2 classes or more can be combined with or without ribavirin to bring about real success in on par, potentially, with regimens given to non-cirrhotic patients. For patients with renal failure, that still remains a challenge to be solved, not so much because of the inherent untreatability of the kidney failure patient, but rather because so many of the important medications, namely medications like sofosbuvir and ribavirin, are completely renally cleared. And so dosing, or safe dosing of those medicines, remains somewhat a matter of an unsettled nature. So until we define the safe ranges of those medications, we will be looking to other medications soon to be released, we imagine the next several years, that are not renally cleared, that can be brought to bear against that group of patients. So I think there is hope on the horizon for these other classes of agents to be of real assistance. And then in triple therapy failures, we talked a moment ago about our success in treating first-generation protease inhibitor failures with combinations of sofosbuvir and NS5A antagonists like decladisvir or ledipasvir. But interestingly, there are going to be even some patients who are failures of, say, pegylated ribavirin sofosbuvir, or sofosbuvir and ribavirin in the case of genotypes 2 and 3. Those patients, it turns out, will quite possibly be treatable with combinations of sofosbuvir, ledipasvir, and ribavirin to potentially improve their outcomes and salvage that, I think, emerging group of patients. All of these data, I think, collectively tell us that the left behinds or the unmet needs are rapidly being addressed through creative strategies using newer combinations of agents, either in the same class or outside of the original class that was used.